Well, listen, everyone, it's 8:05 p.m. on the East Coast, 5:05 in California, and all points in between. Good evening and good afternoon, and welcome to what is our second town hall of the week. We conducted one last night with about 55 of your colleagues, so we've had a bit of a rehearsal, did a little bit of fine tuning, and we're ready to kind of engage in what we hope will be a meaningful conversation with each of you this evening. I'm Jim Mcdonald, Executive Director of Headstrong. I'm just crossing over my 1-year anniversary as the Executive Director. And there's a lot been going on in the organization that we want to share with you. But to begin, I'm joined this evening with my wonderful colleagues. Dr. Amy Williams is with us this evening. It is day 3 of her tenure as our Chief Clinical Officer. She and Miguel Acevedo, our Deputy Director for Programs and Business Development, who many of you know, have been together in New York City this week with Weill Cornell Medicine, as was I earlier in the week. And then we have our Deputy Director of Business Operations, Lois Lebowski. And you know her from all your billing, exploits over time with Headstrong. Lois is the one who make sure that we keep you paid and keep track of all the sessions that are ongoing. And then a new face, you've probably not met him yet, but Parsh Babishi. He's with us this evening, and Parsh runs our business intelligence and a bit of analytics for us. And we have an interesting conversation for you tonight that we're going to get right into. And we're also joined, and you won't see her, by Laura Dirtz. She's flipping sides for us in the background. She's our marketing director. So Laura is keeping the train running on time this evening, but together we welcome you to this town hall meeting. We've got an interesting conversation lined up. We want to share with you a bit of the background of the last year, where we've come from and where we're going. The strategic plan for Headstrong is known as Headstrong 2025. I'll give you the bottom line up front. Next slide, please. It lays an audacious vision for the organization to kind of carve its trajectory for the next 5 years. Tonight, we're just meeting to make sure we give you an overview of that plan, bring you up to speed on the changes underway, and most importantly, address your questions and listen to your comments along the way. We'll pause periodically to kind of make sure that we've covered some of the major muscle movements and given ample time for conversation along the way. We have safeguarded time at the bottom for more Q&A and closeout, but we're together for about the next 90 minutes, the Headstrong family. We are recording this so that we can share it with those who couldn't join last night and this evening. And a thank you note with the links to the recordings along with the slides we're using this evening will be sent to every participant, those who did participate and even those who couldn't make it, so they could take advantage of the recording being offered. So the first part of the discussion, I'm going to kick off the evening or the afternoon to talk about Headstrong 2025. And I want to go back in time to about a year ago, about 6 months into my tenure, when the board and the executive leadership of Headstrong and outside consultants gathered to begin a strategic planning exercise to look at the strengths, the weaknesses, the opportunities, the threats that exist to Headstrong, and really put forth a noble effort to put together a 5-year plan. And I've been in the Army 26 years, so I know there's a lot of plans out there, but key to this discussion tonight is how we're executing against that plan. So the plan is actionable, and we'll walk you through the big elements of it. But I want to make sure you understand at the top that it was developed very deliberately with outside voices, the board, the governance structure of Headstrong, the partners of Headstrong, as well as outside consultants that helped us guide the process along to put together the plan itself. In that plan, the board has established a very big vision and a very audacious goal for this organization by 2025. And it's rather simple: to be able to address the mental health needs of any military connected member or family member anywhere in the United States by the year 2025. And where we currently sit as an organization is we're resident in 28 program communities, 12 states, plus the District of Columbia. But as I get into the conversation tonight, you'll see just how deeply we are connected across the country and what that trajectory looks like to be able to blanket the nation with Headstrong resources, you, our clinicians, to be able to address the mental health needs of those who serve their country and their family members. So the big muscle movements from the top. One, we're bringing in-house on a full-time basis the entirety of our clinical operations infrastructure. So everything we had in Weill Cornell Medicine is now coming inside Headstrong and being led by Dr. Williams. And we'll talk in detail. Amy's going to jump in after me along with Miguel and share with you a little bit more granular detail about the plan. But the big news is to bring all of that in-house on a full-time basis, committing additional resources on a full-time basis to establishing the conditions for greater success for our clinical stance over the next 5 years. That does include bringing in full-time, on a full-time basis, redundant intake and referral capacity. So, and as of today, as of Monday, actually, we are managing all new intakes in-house under Dr. Williams' leadership. So those two big pieces are really big elements of the transition underway inside Headstrong to really enhance our clinical standing and the operations associated with our clinical operations. Another element of the plan will see us establish nodes of clinical support in geographies to be able to provide more responsive reach back capability for things like case conferencing, case consultation, you know, the stuff that you engage in daily with Gerard and Dr. Beater and others to make sure that any hiccups along the care trajectory of one of your clients, a check-in is required, or just the regular cadence of providing feedback on things. We're taking measures to decentralize that on a regionalized basis under Dr. Williams with clinical partners dispersed across the country. This year, we'll see us establish two, one east of the Mississippi, one west of the Mississippi. Next year, we'll double that so that the Headstrong footprints will look like 4 geographic nodes connected to Dr. Williams and the clinical operations team to enhance our ability to support you, our clinicians, on a more responsive basis. There's equity involved in that. What we do for one clinician, we want to do for all. We want to make sure that all clinicians enjoy access and reach into the clinical capacity that Headstrong's clinical operations team leads and manages under Dr. Williams. And very exciting, in my opinion, is that next year we'll roll out an education and training component to Headstrong to help our clinicians stay ahead of the curve of innovation, to help with protocols as they emerge that we want to adopt, to look at measurement and evaluation through the lens of how does it help the organization articulate its efficacy, what you all do. The bottom line is to put in place a regular cadence of education and training on demand and otherwise that you'll be involved with as our Headstrong clinicians, you know, bringing you forward to help normalize what it looks like across the Headstrong model across this country. And then lastly, I alluded to it before, but and this comes to us from COVID, when March 2020 hit, as you know, we didn't turn off the lights and you all kept serving people. Now there were disruptions and there were things that we had to pull back on, but unlike a lot of other treatment practices, telemental health became something that we adopted rather quickly. And what we did with it so much, it's now part of what we're referring to as our hybrid model, that we will retain a telemental health stance alongside our physical delivery of mental health treatment. So the hybrid model is the new model in Headstrong, and 2 things we discovered along the way. 1, telemental health afforded us unprecedented access to people in hard to reach pockets of this country. It opened up access and it created pathways to care and treatment. So much so that demand remains strong for you, our clinicians, all over the country. But it also did another thing. It taught us that we no longer had to think of our clinicians as sitting in Albany, New York, Phoenix, Arizona, Atlanta, Georgia, Seattle, Washington. You're all licensed by your respective states. Some of you hold multiple licenses. So the thinking went, with telemental health, we're capable of addressing the needs in these states through telemental health. And so we realized along the way that to take advantage, as much advantage of the circumstance as we could, we think of ourselves now along these geographies and no longer cities, specifically states, and more specifically, what the VA refers to its Veteran Integrated Service Networks, which are numbering 18. You might be surprised to know that the way the VA carves up its medical resources, it does so geographically in 18 distinct geographies. Guess what? Headstrong clinicians, you are resident in 11 of those 18 geographies, leaving 7 uncovered, hence the 5-year plan to go anywhere in the country by the end of 2025 through Headstrong's expansion, which we'll get into further in a moment. I'll leave the clinical growth in market to Miguel and Amy. They'll talk about it in greater detail. My job at the top of the Zoom was to simply introduce you to the concepts associated with the change management underway within Headstrong. It's very exciting. Feedback has been very positive. Last night's crew of clinicians enjoyed the discussion greatly, as I'm thinking you probably will. And we'll give you a little bit more granular detail about this as we move forward throughout the evening. The next phase of this, I'm going to turn over to Miguel and Dr. Williams, Amy, for their conversation. At the bottom end of this, we're going to enjoy kind of a brief walkthrough of the new Clinician Portal with Parsh and Lois, who will walk you through what is going online next week and the change associated with that to streamline, I think rather intuitively, both invoicing and your ability to kind of report outcomes and manage clients. But we'll save that for a moment. I just had the honor of teeing it up. The last thing I say before I turn it over is I so deeply appreciate what each and every one of you do every day for members of my tribe and my family's tribe. And I'm glad to be here, and I'm glad with the challenges ahead because I know we have a great team in the field doing wonderful work. So at this point, I'll turn it over to Dr. Williams and Miguel, and thank you again.
Thanks, Jim. All right, so I'm thinking that you guys made a really good decision to get on this night's town hall because it's my day 3 and I've learned so much in the past 24 hours. So you're getting the benefit. I mean, if we can have another one tomorrow and we'll see what we've learned by then. So I really actually just wanted to take a minute, and I appreciate Jim, you kicking us off and giving the larger vision. And I just want to say thank you to everybody for getting on at the end of your workday. I know that that's no small feat, so I really appreciate you being here. And I wanted to take a second just to introduce myself, say a little bit about who I am, what brought me to Headstrong, and then we can jump into the nuts and bolts of vision and, what we're thinking so far, which is actually changing by the minute. And I want to tell you like a little bit more about how I think that through and where I'm kind of prioritizing so you can get a feel for it. Because I know like this is a big shift. So first of all, for me, I am a psychologist. I am based in Dallas-Fort Worth, even though I'm here in New York this week and thinking that I'm going to say, okay, I'm going to come back to New York every spring in early summer because it's beautiful here. And so I will be working remotely in the Dallas-Fort Worth area. I used to have a private practice. And when I was in private practice, I was also doing adjunct teaching and training. I'm a national trainer for cognitive processing therapy, one of the EVPs for PTSD. And so in doing that work, I was approached to start one of the first Cohen clinics. And if you're not familiar with the Cohen Veterans Network, they do some really similar things to what Headstrong is doing, except they have a different model in that they use brick and mortar. And also so they've got these clinics across the country that people have to come to, except for telehealth, right? And in addition, they have a time limited approach, which, by the way, that's one of the questions that's come up, and we're going to address that tonight. We are not changing the approach that Headstrong has used in terms of not putting session caps on treatment. That's not something we're going to start doing. And I know that that was a source of maybe some concern for people. So I just want to put that out there. I love the Headstrong model. I love that we really try to serve all eras. I really like the idea of using therapists that are already practicing and then tapping in and matching people. It gives us so much more flexibility to really make the most and really give our clients what they're looking for. So that's just a little bit about me. And that's the team, by the way. That was my day one. So I feel like every day I'm going to have all these memories of, I don't think next week's going to be like that. But the team here is great. People are dedicated. There's some board members there. I will tell you that everyone is super excited to make this work. And every idea that I have come to people with in terms of like, hey, I think we could try this or this has been met with enthusiasm. And you are all part of a really great organization. And I'm sure you already knew that, but maybe you're seeing a part of the organization that you haven't seen before. So Miguel, I know you know a lot of folks. Do you want to say a few words before we move to the next slide?
No, yeah, I just want to thank everyone for really joining and listening to us and getting to hear from us directly about what the vision is. I've thoroughly enjoyed working on this plan, but again, I just want to thank everyone for taking their time out of their, end of the day work day to just sit here and listen. So thanks, I appreciate it.
So Laura, if you want to advance the slide. So one of the things I want to run through as I'm running through this, I'm assuming that people are going to start to have questions, start to have thoughts. Please pop them into the chat. You don't have to wait. Last night we ended up having some conversation throughout, and I think that's great if we can be interactive. So feel free to pop things into the chat. I know Jim will be watching it. And then we can also follow up with things later. So we kind of arranged what I wanted to talk about into these 4 categories that definitely have overlap. And I want to run through them one by one and speak to some of this has even changed since last night. Some additional ideas that I have had, things that have come through. I want you to know that everything that I do in terms of clinical process is going to be focused on, number one, who we're serving. I always want to be putting them first in terms of making sure we're getting back to people, making sure we're getting them into care, making sure that we're doing a good job on intake and matching people with who they need to be matched with, and making sure that it fits our philosophy, that these folks are appropriate for outpatient care, that they're appropriate for our model. And then the second tier for me are really the providers, because without you, we're nothing. So I want to constantly be thinking about how can I make your life more easier. I want to respect your time. I want to respect your expertise. I don't want to get in and micromanage your practice. I want to take what you're already doing really well and see if I can help and augment it. And then somewhere along all those other lines are what everybody else has to worry about in this organization, things like funding and billing and all those things that are important. And I'll be paying attention to those as well. But I want you to know that that's how, in my mind, I'm going to be making decisions at all times. I'm going to be prioritizing clients and you, the providers. I know there are some people on here that aren't necessarily clinicians, so I need to be mindful of that, but I know a lot of you are. So in terms of our culture and leadership, we're going to continue to be cost-free to the client. We are going to continue to keep things as simple as we can in terms of the process. We're not changing that entrance to the portal. People are going to get, they're going to, put their information in. We're going to reach out to them. We want to keep that as simple as possible in order to reduce the stigma that people can sometimes experience in terms of trying to get care. And as I already mentioned, we do not plan to have any kind of session cap. The second piece of that is what I've already talked a little bit about. You are all doing good work. You're all experts. Everybody, has certifications. People have a lot of knowledge. My goal is to help continue to foster that, and then to help us talk to each other even more, to really beef up the clinical consultation, to make it helpful in whatever way possible, to think about, and this gets into that education and training. How can we start to make sure that if you've got one mechanism in your pocket that you can do not only EMDR, but also PE, or maybe, you're interested in picking up DVT, how can we bring together best practices? How can we talk about how we're serving this population, which is really important too, as we start to expand who we serve. And so I'm super excited about building upon the expertise that's already there. And we've been talking about the education and training piece, and I love that aspect of what Headstrong is thinking about. So that's the first piece, and just in terms of like how we're thinking, what we're planning. The second piece is the case conferencing. So I know that right now, I know more than I did even a couple days ago after talking to Weill Cornell about the bi-monthly case conferencing. We're going to be looking at that using those clinical notes that Jim talked about, really making sure that you have a space where you can talk to other providers and say, okay, this is what I'm doing. This is what's working. This is what's not working. What resources do you have? Really trying to make your life easier as a clinician is the goal of that, and figuring out by that too a feedback loop that we can start to hear from you what's working and not working in terms of what we can bring to the table for you. We're going to continue to give you billing support. We're going to be showing you the portal. I'm already thinking about what we might want to do differently in terms of even the engagement with that. And one of the things I floated today was, do we really need progress notes every session? What are we doing with that? Let's make sure that what we're bringing, what we're getting from you. So I know we need data. We need, outcome data from our patients. That's something we're hoping maybe we're going to be getting some kind of a portal for clients to be able to enter in the long run, so that you're not having to do that data entry. So we're looking at things like qual checks. We always have to keep in mind being careful with HIPAA, PHI. I mean, that's going to be the at the forefront of what we do, but at the same time, trying to make things easier and still get what we need, and looking at what do we really need? What do we need from you in order to tell the story to people about what we do so that we get to continue doing it, but also not to be burdensome. So along with this provider engagement, obviously goes continued referral processes, being able to disseminate to you either in those case conferences or in another mechanism, perhaps a portal or a newsletter, resources that we may find out about that you can plug your clients into in your geographical areas. And then we also have an Innovation Next fellow group that is giving us continuous feedback and saying, okay, these are people that have been tried and true providers for Headstrong and are giving us feedback on, hey, you might want to look at this or that, which is where a lot of these ideas that I'm bringing to you today are coming from, is feedback that we've gotten directly from our therapists. And we really, really want to hear from you. Therapists, psychiatrists too, as well. And so I just want to emphasize that as much as possible, that there's an open door, and that's why my email was in that previous slide. And I've heard from a couple of you already, so it's kind of fun to see your names and see you here tonight. The third one is access. So we want to work on increasing our capacity. Right now, post-COVID, it's a tough time. There are a lot of people coming out of the woodwork looking for mental health. Providers have been providing mental health under these circumstances. We're tired, right? We are overrun. So we're trying to figure out how can we increase capacity. This is where the telehealth, I'm going to jump around a little bit, is really exciting to me, because it does mean that we have broader reach, but it also means that you can have more of the types of clients that you want to have in your practice. Because if I know that you like a certain type of client, then we can match you with that person. So my thought is, the more we expand and the more we increase capacity with providers, then the better we are able to match and give you the type of practice that you enjoy. And so that's going to be mutually beneficial. In addition, we're looking at not just PTSD. We're looking at treating any mental health diagnosis, which also means when we look at our measurements, okay, we can't just give the PCL5. Right. So we've got to look at what are we doing there. And I'm going to tell you a little bit about intake. I've changed the intake form, and I'll tell you what the latest iteration looks like in just a minute. And then we also want to look at clinical orientation. So right now, there is a great deal of expertise in EMDR in the organization, which is great. And we want to continue to support that. We also want to continue to bring in other things that maybe you all are already doing. I know a lot of you are doing other things and other approaches, and we want to continue to broaden that. So I'm going to make a call out to you tonight, given how busy the world is. You are obviously people that are supporting Headstrong and interested in the work that we're doing and feel good about it. If you have other people that you think, hey, this person would be a good fit, maybe they weren't EMDR certified, so before I didn't really think about that. We would love it if you would connect us with them and let us know, because we're looking to add providers to handle the influx that everybody's feeling right now. And this is a great organization to be a part of. So it's an exciting time to be able to do that. And then last, ePassport is just a really cool thing. I believe if you're a psychologist, you may have heard of it. It allows us to practice in up to 25 states have enacted legislation, and even more are coming. And so it's a really exciting time to think about being able to cross state lines if you have that e-passport. And social work, I know, is already starting. So it's starting with social work as well. So I think that's going to really help us over time get to that vision that Jim was putting out there of really trying to, anywhere you are, we're going to be able to serve you, even if we don't necessarily have a provider in that state. So I just saw something come through the chat. If someone is interested in becoming a provider, they could reach out to either Miguel or myself, but I'm going to say me as a point person right now, because we've got a lot on Miguel's boat has been loaded. So come to me, because I'm super excited, and we'll work with them to figure out, like, have them look at the website. There's some great information there in terms of what it needs to become a provider. One of the things that I haven't gotten to is we are going to provide you all with a new MOU that goes through, because the MOU currently is very Weill Cornell heavy. So we need to redo it and, talk to you about what it's going to be like moving forward. That's going to be coming to you in the next month. We could share that MOU with people that are interested, because it really lays out what it looks like. And of course, you can tell them from your experience. So feel free. It's amy@getheadstrong.org. And then the last column to me is, this is the one I really care about, is really trying to prop up and to continue to do evidence-based work, to tell people about the interventions that we're doing and that we're using best practices, to beef up training opportunities that will just be available to you as a perk for being a Headstrong provider. And the last one, the CAQH, I want to talk a little bit about that. If you've not engaged at all with insurance, you may not have a CAQH profile, but CAQH is a nonprofit organization that basically was put into existence to bridge that gap, so that every time you got onto a new insurance panel, you didn't have to fill out pages and pages of paperwork. You put it into CAQH. And CAQH has some things that we're really interested in as an organization. Rather than have to get 300 therapists every year to make sure you've sent us your liability insurance and your new license, it all goes into CAQH. And in addition to that, it's got all your demographics, so that we can run reports on, we know, okay, you identify that you're Spanish speaking, that you're bilingual, or there's an ethnicity part there. If we have veterans or family members who are interested in maybe a person of color who wants to also meet with a person of color. So it's part of a diversity and inclusion initiative for us. In addition to that, it allows you to list your specialties, just it lets us know who you want to work with. So we have some of that off websites and CVs, et cetera, but it's a way to keep it updated. So we're always right there with you. I will tell you, it's a little bit of a pain when you first have to put everything in there. That's a little bit of a burden. After that, it's every 120 days. It takes about 5 minutes to go in, reattest, and you're done. So that is something that we're also going to be rolling out. And my vision is to have like another meeting where we can do a Q&A about the MOUs, the CAQH, all that good stuff within the next month. And we're going to be sending that out to you, so it's not something you have to worry about right now. But I just wanted to kind of put it on your radar while I had you here. Intake forms, I'm just going to circle back. I'm super excited. I've been working with our new intake specialists that we've got. I mean, you may be hearing from them, Robin and Kathy. They're great. And they are helping us to kind of bridge this transition while we hire someone full-time to be permanent. And we've been looking at the intake work, and they started asking me, well, why aren't we doing this? And it was the same things I was thinking. We're going to start giving you intake packets where you're going to get a PHQ-9. You're going to get a CSSRS, the Columbia Suicide Severity Rating Scale, which we're going to be giving you if somebody is higher risk. We're going to be setting them up with a safety plan that you're going to get coming in the door that's already in place. We also are going to, I'm forgetting one. What's the other one that I incorporate? The PCPTSD, the primary care PTSD, which if you're familiar with it, it's just a really easy way to be asking those questions of people with trauma. And then we're going to ask about substance use. And if they do have some substance use, we'll give them the CAGE aid, which is the one that includes alcohol and drugs. So we're going to have some objective measurement going in that you're going to just get and be able to review. And we'll also be able to put that into our database, which eases up you having to give us that stuff right out of the gate. So trying to do more of the work and the legwork on our end versus, having it fall on our providers when we're just trying to get people into care. So I know that was a mouthful. Do we want to stop for questions?
I think it's a good idea if we do right now, Amy. And for all our clinicians and psychologists out there, this is an opportunity to kind of probe deeper into the plans and ask Amy and others any specifics that you're looking at. Or comments. Could go either
Yeah,
way.
it doesn't have to be a question. It can just be
Correct.
like, you know, thoughts that you're having. And like I said, no, I just threw a lot. So if it takes a minute to digest, I want to just suggest to you, and this happened last night, folks, a few people emailed me after ePassport is such a cool thing. Okay, so it's part of PsyPact. And so that's PSYPACT. And if you Google PsyPact, it'll come up and you can see what states have enacted legislation and what ones are pending. All in all, there will be 31 if you include the pending, including DC. And what it means is if you're licensed, so I actually have a PsyPact ePassport. I'm in the state of Texas and I'm a licensed psychologist. It allows me to, in any other state that's participating, to practice in that state by telehealth though. Like it limits, you can't just go set up shop. Like I can't go set up shop in Colorado because I want to have 2 practice sites. If you're actually going to have a physical location, you have to get licensed in that other state. But it allows you to basically see your folks wherever they go, which is really super cool, especially with our population, which tends to be a little bit more transient, especially as we start to serve active duty. It puts us on the same plane as DOD, VA that already are able to do that because they're federal. Okay, let's see.
Amy, there's a couple more questions in the queue.
I've got it up.
Yeah, Dr. Crane asked, are you going to create a separate intake process for kids and teenagers?
I love that. In fact, I just said that today. I'm like, all right, we've tackled the adult one, but there's not anything in here for kids. So yes, that's on my radar, and that is going to be next. I'd really like to, and I'd love to hear your feedback in terms of brief objective measurement. I wasn't crazy about the ones that we were using at Cohen, to be quite frank with you. I don't know that there are great ones because there's such a range. What you use with a young kid would be different than what you use with an adolescent. I like the adolescent measures better. But yes, I definitely think that that's an area for us to be a little more fine-tuned, because right now we've got this one instrument that really is geared more towards adults and was geared heavily towards PTSD. And as we expand, we need to address that as well for family. You know, a family member, we're asking about all this stuff about service. Well, a family member may or may not know all of that. And so really trying to be sensitive to, you know, that shift.
Thanks, Amy. A couple more in the queue and I'll be your reader this evening, amongst other things. Carrie writes from Colorado, I'm a neurofeedback provider in Boulder, Colorado, and all referrals come to me through Headstrong therapists. Is that going to change?
Well, I mean, would you like it to? And you could unmute. I know it's that sometimes the chat's.
No,
I mean, I guess
it's a really simple, elegant process. I work with Lindsay Ryan and a couple here and there, another therapist in Colorado. They send them to me. I do the neurofeedback. I submit notes, but I also work with them, and we talk about the clients and how they're doing and such. It's real simple.
it sounds beautiful. I don't want to mess with that.
It's a very nice process, and they have supportive therapy while they're doing their while they're doing their work, and it's really good. So
yeah, I love neurofeedback, and I think that sounds like a great setup, a perfect setup of providing wraparound care to people that's working and that people I'm sure are liking. What I will say to you is hearing about that makes me think, okay, how are we capturing that? Right? Like, how are we capturing that that's happening so that we can tell that story? Because that's a good thing. So as I get to know what you all are doing and how it's working, that's exciting to figure out how we can capture and convey that maybe in an elegant way.
Mm-hmm. Okay.
Thanks.
To capture the work you're doing, right? I mean, at the end of the day, I want to be able to tell that story.
Lindsay's the therapist that refers to me she's very full of Headstrong, and I'm very full of Headstrong. So it's delightful work. We love it. It's great for PTSD. The combination is very powerful. So
yeah, I'd love to talk to you more about that.
Sure.
Yeah, my My son actually did a dose of neurofeedback several years ago, and he loved it. And so it was. So I'd love to talk to you more about that. And the thing is, when we talk about evidence-based practice, yes, there's the tried and true, cognitive behavioral approaches, and then there are some that just because something isn't in a clinical guideline doesn't mean that it's not going to be there at some point. And we need to be careful that we never confuse these treatments that have a lot of research behind them. That just means they have a lot of research. The other ones may be coming. And so one of the things I'd really like to think about at Headstrong is we want to lead with evidence-based approaches. We want to lead with evidence-based practice. And then we want to be open to other things that are up and coming that, may have evidence, and we need a stronger base before it makes the DoD guideline, but that we're still open to it. So I do want to convey that my goal is not to kind of turn us into automatons and get away from what's already working in the field. And so I really just want to hear about it. I want to know about it. I want to be able to capture it.
Very good. Thanks, Amy. Next question. Will clients, and this is one we had last night, Kathleen writes, will clients be able to fill out the requal/PCL5 maybe during session, but send in themselves? Could we maybe provide them a link for this? And this is a conversation you and Miguel carried last night. So I'll ask you both to kind of talk our guests through that.
And Parsh as well. So the pie in the sky is that we will be able to send them a link. They'll be able to do the measure. It will go into the Headstrong portal and you'll be able to access it immediately. Now, we're not there yet. So for right now, the non-pie in the sky is it's still paper and pencil or fillable PDF or however you're doing it. And then you're having to data entry that. So that's not where we want to land, but that's where we are now. But the goal is to get to that other place.
And when we get to kind of the later section on talking about the Clinician Portal and some of the changes in Headstrong's data architecture, I'll kind of shed some light on why that is, but our optimism as well on getting to that solution for all of you.
Yeah, or we could even just during the session, just give them the link. That way, if they get triggered, they may or may not.
Yeah,
Right.
Yeah.
that actually came up last night as well, Kathleen, the triggering effect. And how to avoid that. So
right. And my goal is to really, I'll just be transparent, is to add the PHQ-9, and that's got the suicide question on there. So we certainly don't want to be given that and having it sit out there for a week and you as a provider not know that they said that they were having ideation.
Right.
It opens you up for liability. So we want to get that timed to where you have control over when that link goes to them and when they're answering it.
Okay, great. Thank you.
And then Sonia writes, next question, if I meet a client or hear about someone who I think would benefit from Headstrong services, is it okay to refer them? I'm not asking if I can self-refer, just in general, if you want us to tell people about Headstrong services for military service members. And I can answer this one, yes, please do.
And it's okay to self-refer. It's actually spelled out in the new MOU.
Yep.
And I think it was in the old one too, that we encourage you, if you have people in your practice that don't have insurance, that aren't able to pay, that if they're eligible to be a Headstrong client, why would we not want them to get care? So, yeah.
Thank you. Alicio writes, are LMFTs included in the provider pool?
Absolutely.
Easy one, good. Next question. Jillian writes, who qualifies for services now, and are there any rule out criteria for services? What services is Headstrong funding? For example, individual therapy, couples, neurofeedback, psychiatry, TMS, etc.
So the hope is that we're able to serve veterans, active duty, and family. And I think, when you look at capacity and getting people into care, my hope is that as Headstrong, we're going to really still continue to really push our veteran active duty service member, but we want to be open to family members as well. But I think I'm thinking we'll push more active duty and veterans when there are capacity issues with our providers while we're growing. Like we're in this pain point right now, right? Of like we're getting all the people need help. It's really the pandemic. And people are booked. Therapists are working hard. So, but all of those groups are eligible. In terms of the types of services, that's going to be determined in your MOU. So we want to have a conversation with you so you know exactly what you can bill and what you can do. But all of the things that you're listing, let's see. Individual couples, neurofeedback, yes. Psychiatry, typically we haven't done med management. And I think it's something that I want to start to look at. I think we've done it maybe on a rare case by case is what Weill Cornell was telling me. But typically we don't do psychiatry med management, but we'll continue to use them for evaluations. I am exploring having non-psychiatrists do diagnostic interviews and evaluations based on people's comfort level as a way to avoid a bottleneck, because psychiatrists are oftentimes the most in demand. So it might look eventually like we're allowing people to do the diagnostic interview, and then we can make a determination, maybe still do get them into the psychiatrist, like do both, but maybe not everybody would need to see a psychiatrist. So thinking through, those are some of my kind of future facing things that I want to start to think through. Right now, we are not funding TMS or, stellate ganglion blockers or things like that. That's a conversation that I'd actually like to have with Jim and the board as we get our current stuff under control. And I'm feeling good about that. Do we take a pocket of money and start to explore and pilot some of these other approaches that have been found to be effective? I think so, but I think first I want to perfect what we're already doing with the providers that we already have on board.
Yeah. And Amy and I have talked about this already. The exercising of discretion, right? It's, you guys talk about it and we'll reach a decision. So it's not a strict codified yes, no scenario. There's individual discretion in mind. And I just encourage us to keep that in mind as you encounter individuals that you're trying to help and have questions about whether or not they're appropriate, these adjunct therapies that are emerging. All that demands a conversation, I think, as we go forward until the pattern is better set. So next question, what are the target timelines from referral to therapy assignment?
And it's funny because I'm not sure, Jim, if you said Jillian was asking these questions,
Yes.
But then I looked in the chat and I see that it's Jillian. Hi, Jillian.
Yep.
And we were together at Cohen for a little bit. So
Oh, wow.
It's so nice to see your face. So we want to be able to reach out to people by email. They come through the portal. So within 2 business days, I want to have an email back to them trying to get them scheduled for an intake. Obviously it depends sometimes on phone, email tag when you actually get that intake done, but the goal will be to make that first reach back out within 24 to 48 hours. Then this is where the conversation becomes, how hard is it right now to get into a psychiatrist, right? And in some markets, it may be easier than others, which is why I'm really looking at, on a case-by-case basis, might we start to talk to providers about, hey, can you do this diagnostic interview? Most of you that have active private practices are doing those. And so I really want to think about that. The one thing that's really nice about the way Weill Cornell set it up was that the psychiatrists were really looking at, is this person an appropriate person for our model? Are they appropriate for weekly outpatient care? Not to say that every now and then you might not do twice weekly if somebody's in crisis, but we're not an IOP, we're not a SOP program. And so if somebody's not appropriate, or if somebody's floridly psychotic and they really need to be led with psychiatry, we don't want to get ourselves into a situation with our providers that you're now trapped in this situation with this referral that we've made you that's not appropriate for your practice. So if we do decide to go where other people are helping with that to get through that bottleneck and helping with diagnostic interviewing, we'll need to have a conversation with just kind of letting people know, like, that's just an interview. And then we decide if they're appropriate for care. And you're going to know. And you're probably going to be the provider. So it'll behoove you to screen that, but not making promises at that evaluation point until we decide, yeah, that's a great client for our model. So that what I hope is that 24 to 48 hours, we've scheduled an intake. Once we do the intake, that they're in with a provider, have an appointment within 5 business days. That's what I would love. People don't want to wait weeks and weeks. You got to strike while the iron is hot and meet people where they're at. So that's my goal.
Very good. Thank you. Dawn asked the question, are we keeping the PCL? Any thoughts on the GAD-7?
Oh, I have thoughts about the GAD-7. I would love to know, Dawn, if you love the GAD-7. We're definitely keeping the PCL for people that have PTSD. If you don't have a PTSD diagnosis, then obviously you'll write NA and will not be giving the PCL, which is why I want to add something like the PHQ-9. The GAD-7 I find is, it's just so broad. It's just like, I don't know. Like when I look at outcomes on it, I don't know. Do you like it? I mean, I hate to say kind of like meh, and then ask if you like it because it kind of puts you on the spot. I mean, I like it for people that are super anxious and that's really what you're tracking. But just to give it as like a blanket measure for everyone, I think it's less useful as a blanket measure is what my concern is. I don't want to force y'all to give a measure that's only going to be good for maybe 20% of your population. I don't know. Like, what are your thoughts? I'd love to hear what you think.
So I'm not married to it, but I think there is a certain percentage of our population that would probably benefit from it. So I was thinking, could it be one of the options that if it seemed appropriate, we have it?
See, and I love this kind of sophisticated long-term plan of kind of you have a, what's the word? Like a buffet. You have a buffet of objective assessment choices that you tell us, this is what fits my client. This is what we should track for outcomes for this client based on their presentation. And then you can dictate what they fill out and then what goes into our system.
Nice.
I'm not sure how close we are to something that is quite that elegant, but I'm sure, Parsh, you're taking notes and I'm taking notes and thinking this through. I love the idea. So thank you for giving it to me, because I do think it does fit really well for some people.
Thank you.
Amy.
I'm not sure about the requal, by the way. I got to really dig into that.
Yeah.
Do y'all love the requal? Is it giving you good data?
Thanks, Don and Anna and others.
I'm not hearing anybody go, yes, but I'm going to look at it because it is good to have that non-clinical measure of wellness. And I don't know in our field if we're really good at how to measure that, but that's on my to-do list to dig into a little bit more.
Great. Christina in Houston writes, I'm a psychiatrist in Houston and have 4 to 5 clients in ongoing med management. Will I be able to continue?
Yes. The answer to will you be able to continue to do what you're doing in any of your minds, the answer is yes. Yeah. If you've been doing it, you can continue doing it.
And then Maggie writes, please, please, please add psychiatry as a service available to Headstrong clients. Access to psychiatry is difficult for my clients due to financial constraints, and the VA is not cutting it in terms of ongoing care med management.
I really want to explore this. I know one way that Cohen tackled it was they basically would provide it as adjunctive when somebody was getting therapy. But then not med management kind of ad infinitum. Because I mean, you could be in med management for 10 years, but not necessarily need therapy for 10 years. So I really think this becomes a feasibility in terms of cost that we need to, as an organization, I need to understand more before I can answer that. And I don't know, Miguel, if you want to tackle that, or Jim, I'm certainly open to looking at it.
I think one of the things we're looking at is really, capacity and honestly being able to generate that is quite difficult now during the pandemic. So one of the things that we've been describing that Amy just brought up not too long ago is really, can we alleviate some of that bottleneck with psychiatry by having other clinicians do the initial diagnostic, and does that free Headstrong up to utilize providers for these types of services? So those are things that we're constantly looking at. And really, once we have an idea of how much capacity we can add, and this is why Amy's call to action is critically important, is can we add and generate sufficient capacity, and what does that afford the organization to be able to do? So those are one of the things that we're thinking about. And it did come up in a call in a question last night, is also how are we looking at reimbursement? And I wanted to take this as an opportunity to also discuss how that's something that we're looking at. We're not going to slash reimbursement rates. I know that might have been an anxiety or concern. If anything, what we're looking at is doing some modeling to ensure to look at how could we invest more in our providers by increasing the rate nationally. So these are all things that we're thinking through, and I appreciate the question, because it is something that we're constantly looking at and addressing is how do we add more capacity, but more importantly, how do we add value to our network of providers who have already done such an amazing job over the last 9 to 10 years. And so we want to think about how moving forward, that is constantly part of the conversation.
Thank you, Miguel and Amy. And this is more of a comment from Jillian. Headstrong made a great choice with Amy. Excited to work with you again, Amy, as much as we are, Jillian. So thank you for that comment. So
thanks, Jillian, for the vote of confidence. It's nice to see familiar faces. And then I see, Jim, the next one about the ACEs.
yeah,
I love the ACEs. I'm trying to be mindful of not front loading. Like, we have to keep true to the, not a lot of red tape. I think people are sensitive to, I don't want to be on with that intake person for an hour. On the flip side, I would like to say, I think it's super important. We used to give it at Cohen to everybody that walked through the clinic, and we gave it at the clinic level. It wasn't a Cohen thing, it was at our clinic, because I believe it is very important and it gives you a lot of great data. So I would encourage you to use whatever measures you want in your practice. We are not getting in the business of your practice with what you think works, with your intake paperwork, with, how you do your record keeping and your notes and what you want to focus on. That all, you will still maintain that independence. We are asking for a couple of things that are specific to us, but I want to keep the burden light in terms of requirements. But I totally agree. If we ever get to the place where we can have people do it kind of easily in an online way, it'd be nice to have that as an option.
Yeah,
so because our marketing director, Laura Dirtz, is going to yell at me, because for the recording purposes, I need to go back and ask that question that was just answered. Amy asked also the ACES questionnaire. I work with a lot of people with complex PTSD, especially of a developmental nature, and find it a helpful screen. And you all just heard Amy's response to that. So, but I know there was a comment coming as well. So please, I didn't mean to interrupt, and please go ahead and ask your question.
no, sorry. My name's Amy as well. I'm a clinical social worker in New York City, and thank you and for responding to that. I just wanted to say I actually do. And I don't know, this is probably more complicated than what Headstrong can plug in, given the broad scope of what you're doing. I use an EHR called Simple Practice, and actually they have some of these questionnaires like the PCL5 and the ACEs that's already online. And so when I've done intake paperwork, that's what I mean, all my stuff is completely online. I haven't done as much of that for Headstrong clients because of the, you guys, traditionally it was already Weill Cornell did the intake. So I was just sort of taking them in, and I might do that stuff later, but maybe not, so I don't, I'm not trying to make it more onerous. I just wanted to throw that out there anyway. So
no, I appreciate it. I'm totally with you. I think it's a great self-report measure.
Next question is from Lauren. She writes, will there be any opportunities within consultation through Headstrong for movement through the certification levels within EMDRIA and or other certifying organizations, Imago, AAA, SECT? So question.
I think this all falls under the training and education umbrella. I would hope so. Like, I hope that we continue to support everything that you are already doing and the expertise that you've built in your practices, as well as augmenting, with additional tools. That's my goal. That's the dream. And so, yes.
Thank you. Kathleen writes, do we maintain access to session notes we submit directly on the form? Parsh, good question for you.
Yeah, so this is an excellent question and a feature that I think many clinicians have asked for. I think on our launch, there will be probably an ability to kind of submit, but in the future iteration, kind of probably a few weeks or hopefully a little after we launch, we're hoping that there will be a repository for you, and you'll see some screenshots a little later this evening on how you can view possibly your session notes. So we hope to have that feature available for our clinicians in the future.
Thanks, Parsh. And I'm going to take what will be the last question, because I want to get into Parsh's Clinician Portal right after this. Charles writes, and this is basically a question for me anyways, funding for this wonderful plan is so vital. Our sense of security as providers depends on the availability of funds for Headstrong. How will that happen? Well, Charles, you're talking to the guy whose business is making that happen, and I have years of experience in these operations in nonprofit settings. I specifically was invited to the dance to be the executive director to put forth such a bold, audacious vision and garner the board's support prior to for doing it. The board approves every budget in Headstrong. They're integral to the financial operations, which are reviewed monthly in this organization. And I have every confidence, not only in my own abilities, but the board's abilities as much as I have in your abilities to make sure that this organization is sustainable for the years ahead. And I'll share with you a very personal story, which I tell everyone. My youngest son is a second lieutenant in the United States Army in the 101st Airborne Division at Fort Campbell, Kentucky. He's a brand new engineer officer. I'm here to ensure that this organization is there for him and the people who fight and potentially die next to him, to ensure that we keep our bond with those who serve their country. I can't say it any clearer than that. The business is enduring. My legacy will be to establish a sustainable platform by which to do this for not only my son, but for the sons and daughters of people like me who contribute to our nation's defense through our own children. So I take this very seriously. I have experienced vastly in doing exactly this work in a number of nonprofit organizations, and you're talking to the guy who has to make it happen every day. And I want you to walk away from this conversation understanding that that's my job. That's what I'm here for. That's what I'm paid to do, is to make sure that you keep doing what you're doing. So that's going to be the last question for the night. Yeah, thanks.
Don't forget, Miguel's got a great slide that kind of puts this all together.
I just
so
wanted
Laura,
to get off the queue.
And I was long-winded, so I'm going to be quiet and let Miguel take it away.
Miguel,
I definitely, I want to get everyone to the portal too, because I know we have sort of anxieties about that as well. But really, what we're all talking about really is how we're bringing Headstrong into this next stage. For us, we did see COVID as a really a point of innovation, not just for the organization, but when we saw so many of the social safety nets fall that were really supporting veterans in their communities that they live, we really saw this as an opportunity, but more importantly, as a call to action as an organization, that we have to pick up this burden where other social safety nets have failed and have either taken away their services or have brought them back in limited capacity. The only people that are suffering are the veterans that are serving. And, being that many of them are my colleagues and people that I served with, it was really important for me to really understand how we could bring the organization to this next iteration, keeping those things in mind, that the next pandemic that hits, because it will, shall not see an organization fall behind. And so for me, this is where Headstrong really has stepped up in a really big way as a major player in the space. But to get there, I think there was a couple of things that we needed to do as an organization. For us, we wanted to be more inclusive and just have a better understanding of all the communities that we're serving in. So part of what we've rolled out now is a deployment of a field operations team. And Jim talked about it before. We're going to break the country into quadrants, and where you have a regional support team that's helping you clinically by providing consultative reach back capabilities, talking to you through difficult cases. You'll also have a non-clinical field operations counterpart whose sole job is to be in the communities, to understand what it is in terms of lived experience, what are veterans facing, what are some of the barriers and challenges that are associated with just getting entry into care by holding these stakeholder engagements so that we have a better understanding of what the veterans' needs are program market by program market, because a veteran who lives in Philadelphia doesn't have the same needs or issues as, say, someone who lives in San Diego, where there's a constant turn, there's an active military duty base. So being able to really adjust our programming to fit the needs of the communities where we serve, I think was critically important. So that's item number one. The second one is really what we're discussing here today with Amy, is really improving our clinical support. And that begins with your internal infrastructure and governance and internal case management. Owning the client experience from beginning to end really allows us, and we've already done it within the short 3 days that Amy has been here, is now that we know and we're living and breathing and we understand that what providers are going through, we want to simplify the process as best we can, reduce the bottlenecks wherever they exist, so that you're enabled to do the practices that you love. which are treating our clients. The other part, and we mentioned it, is the deployment of the regional clinical support teams. This is where, rather than having to wait to hear back from somebody in New York, you'll have a more localized regional clinical support team, someone who serves, has experience in Headstrong. We are going to elevate Headstrong providers that have been with the practice for a very long time, who know what it's like to work with our population, to be able to support you on a more regional basis. So rather than waiting for someone like Amy or someone in New York to answer a question that you need, quick answers to, you'll have a more quicker response time so that you can continue to do the work. And more importantly, just improve your overall experience. One of the things that we learned during our Innovation Next Fellows, listening to them, listening to their feedback, a lot of them felt isolated in their practices despite the case management which was happening. And I know we were grateful for what was established, but when you have really high-risk clients and you need just greater reach and greater capacity to reach out, that's one of the things that we wanted to improve. And so this is where the concept of the regional clinical support team comes from. These are your peers. These are people that have served in the Headstrong network, and we want to elevate them to be able to provide support to you all to continue doing great work. And then the last piece, which is really where Parsh is going to enter, he and others have spent an enormous amount of time really thinking through, looking at the client journey and really bringing in and introducing innovation and technology through our deployment of our clinical portal. And it really helps us accomplish a couple of things. One is improve our digital outcome measurement. It streamlines the process a little bit better. We did talk about the pie in the sky, the way we want to be able to do this, but it takes iterations to get there. But at the very least, we wanted to be able to establish that capacity through this portal so that it helps us understand as an organization, are we doing right by the people that we're serving? Ultimately, that's what we want to be able to answer in a way that doesn't become onus on the practice, on you as individual practitioners. We definitely don't want to make it harder. We want to make it easier. And then the last thing I'll say, really all of this combined for me, having served, but also more importantly, having gone through the program myself, I really can shed a little bit of light wherever I can to really think through what the challenges of new waves of veterans that are coming through, the challenges that they face are not going to be the same ones that I face coming out of OEF and OIF. So for me, it's critically important to set the organization up to be responsive and adaptable so that we are meeting all collective needs, not just like niche population. So all that being said, I do see this as a tremendous opportunity. And we're grateful for all the work that we've done so far, and we only want to continue to make that even better. So Parsh, I'm just going to pass it over to you to briefly talk about the portal, because I know there's a lot that we want to discuss, but really thank you all again for taking your time to speak with us tonight.
All right, thank you. First of all, it's a pleasure to meet all of you. Let me just introduce myself. My name's Parshva Vivishi. I, alongside my colleague Kelsey Custer, run the business intelligence team here at Headstrong. But what does that really mean? So what we do is we look at kind of analytics. We look at trends. We manage the Headstrong database, but really prepare this organization for sustainability, looking at technical solutions. So technology is a really big component of what we do. And we kind of hope that this solution we have here is the start of something that will really help pull all of us together in the future, as we definitely heard from some changes from my colleagues earlier. So if we move into the next slide, essentially what we're going to be doing at the end of this month, starting June 29th, is launching Headstrong's Clinician Portal. And what that really is, it's going to be a digital space that really covers 3 areas. One, kind of centralizing caseload management, being able to look at active clients, closed clients, who's in the queue and pipeline for you, especially as we assign clients to your practice. The second component, I would say, is clinical assessment. So we've talked a little bit about this earlier on in the discussion, but really being able to track client outcomes in a more expedient manner digitally, looking at those results on an aggregate level to help Dr. Williams' team to make the right analysis, but also to be able to help all clinicians across our network to track and enter client data through some of these assessments. And then lastly, I would say to make invoice and session recording an easier component in Headstrong, to be able to log that in one area and attach notes and kind of review that process. So doing these three things and looking at these three pillars, I would say, was the impetus to start, I guess, at the end of last year, of looking at a solution to really bring all of this together to have, at launch and ready for all of you this summer, and really tie up to what Jim talked about earlier at the presentation of our vision of Headstrong 2025. So just a little background, and I'm cognizant of time here, so I'm going to try to be expedient here in some of these screenshots and slides, but these are just some areas that I'll be talking about, a little background on the project itself. We'll dive a little bit into the features and have a discussion, and I'm sure there'll be some questions on how the portal's used, but essentially we'll end with how this helps you and Headstrong as an organization, and then really the transition and timeline when we go to launch. And also to be cognizant of the features and changes that we may want to put in place for the future as well. So I won't definitely read off this slide for you. I know it's late for sure, but just a little bit of background here to talk about the timeline. Really, this has been quite the journey here. I've been at Headstrong for a little over a year now, and we started this process back in November and December of last year of kind of gathering all these requirements of what would make the best use of a portal, not only for our clinicians, but in terms of business requirements, what makes sense for Headstrong as an organization. There was a question earlier about how do we look at funding for a lot of what we do, and this also kind of is a way to be able to determine that as well, being able to kind of collect this data in a more expedient manner to help Headstrong grow and be sustainable in the future. So as you can see here, some of the components we looked at, making sure that we have HIPAA and PHI compliancy with whatever we launch, that we do our due diligence in the discovery phase, looking at how this portal can help not only the clinical team in Headstrong, but the marketing team, for example, our field operations team, and my team in the analytics division as well. And then lastly, moving on to the build phase, and then finally the launch, which we're hoping to do by the end of June, early July. Great, so we're going to talk a little bit on the screenshots and some of the features that are available for everybody here as we go into the Clinician Portal. And so what will happen is at the end of this month, everyone will receive a welcome email and packet that kind of details out the new changes to our portal. There'll be a frequently asked questions guide, training videos, all ready for you at the launch of this portal, but essentially you'll be able to set your own password and then log into Headstrong's branded portal. In an effort to stay in line with all healthcare providing companies across the world, we'll be moving to a more secure data management system, and it's commonly known when people log in as two-factor authentication, which we'll be looking to roll out at the end of this year to help provide extra security for client data and your data as well. Great, so what is the secret sauce here in terms of the main view of this portal, and what can you really do? So essentially this will be the home page of the Clinician Portal. Now, before I dive into this, I kind of want to make a statement here at the top. Essentially, as we go to launch here, this portal will always be an iterative process for everyone as we go along. So if there's changes that need to be made, if there's things that we need to switch around, nothing here is set in stone, and as an organization, I think we value transparency very highly. So as we listen to more feedback, we'll be more than amenable to make the right changes. But up at launch, what you can see here is a few key areas. One is the ability to submit new sessions just by clicking one of these main modules, clicking and viewing your open cases, looking at your closed cases, updating your personal information for yourself and your practice, an FAQ guide where we'll be uploading information on the portal, information from the clinical team, and anything Dr. Williams may want to provide in terms of templates and best practices, and then a callback to our Headstrong website to be able to showcase some of our most leading events and things to be looking out for from an organizational point of view. And just as an aside, I've added an additional layer of redundancy here. So not only can you navigate to these functions and these modules, but the top navigation bar is another way to get to all of this as well. Awesome. So account information. So really just your personal information and always kind of being in tune with Headstrong. So this is kind of the source of truth when it comes to email information, name, address, kind of where you're located, phone number. We need to kind of centralize this information and be able to have real-time access to be able to send information from an organizational point of view. So this is kind of an easy way to always have that information updated and at the ready, especially if there's a change or you move or there's just a difference in how to reach you and the best way to do that. Awesome. Okay, so viewing cases. So earlier I spoke about clicking your open cases, and you can navigate that from your navigation bar as well. But this is just a quick look at kind of viewing your open cases and active clients essentially. And this is all automated already using our Salesforce database architecture from the back end. And I see a note already coming in about it's this question for later, but I'll just talk about it very quickly now. Should we do June notes in the new or old portal? And I'll talk about that once I get to the end of this presentation, and then we can have probably a larger conversation about that as well. But essentially in this view here, you'll see case number, you'll have patient name, type, so therapy, or if they're in psychiatric evaluation, for example, the session count of those clients. And then we talked briefly earlier about some of the outcome assessments that we're hoping to track from a digital perspective. So historically, what we've done is we've been tracking the data track. We use the data tracking form, the PCL5, and the requal. And obviously, there's going to be some changes as Dr. Williams and Miguel and the team have spoken about. But for now, this is to give you an idea of what that's going to look like. So you're on top of being able to see which clients may have outcome assessments that need to be delivered. So obviously green flag is a go, and a caution flag is an assessment's coming up that's due for this client. So here, just as an example, you'll see for the top row for that client that the data tracking form, the PCL, and the requal, since it applied to that client, all have been flagged green as they've been submitted. And we'll be able to go into what that looks like, those forms exactly, and those views at a later screenshot.
Awesome. Can you address the question by Dr. Crane while it's timely? I'll read it. Dr. Crane asks, will we have the ability to enter 2 addresses? We may prefer billing, etc., to be mailed to home address when doing telehealth and have an office address as well.
Great. So at the moment, there's only room for 1 mailing address, which is your main point of contact. But in the spirit of kind of being transparent here and being able to work with all of you, we can look into some additional functionality as well to open that field if that one doesn't apply. But also in the interim, on a case-by-case basis, we can also make those changes on our back end of our system, so we can track that for you. But that's a good question as well as we think about expanding our network countrywide.
Thank you, Parsh.
No problem. So adding sessions. So essentially kind of as many of you are familiar with our old portal and our old system, looking into adding new sessions here, and you can add multiple sessions through this view here. But essentially what you'll be able to do is once you've already logged into the portal here, you'll look at the client name. You'll be able to click into that drop down essentially and type in a name or the first letter of a patient name, for example, and click. And that's already tied to your caseload. So all you would have to do is just find the correct patient and just click it. And then the case number will be auto-populated for you. So you don't have to find that. And we've added here, you don't need to change that at all. That populates from our system. And then there'll be the subsequent fields that are necessary for session input, such as the date, attended, and you'll have drop-down availability for types and session format. Now, we had a question earlier about notes and the frequency of notes, but at least from a functionality point of view, what we're going to allow to do is an either or option in either attaching notes as a PDF or Word doc, whatever you might be familiar with in terms of an attachment of a file, or entering a text version of a note if you're just copying, pasting over, for example, from a computer or a cloud-based system, if that's what you're using. And so when you click enter notes, a text box in the same screen will open up, and you'll just be able to input that information and submit. So that's a little bit about case session entry. So let me just stop really quickly and just answer some of the questions. So I believe the frequency, Charles asked, I believe the frequency of some of the inventories are excessive. So I think, that's probably relative to the frequency of the assessments. And I think Dr. Williams is probably better to answer some of those changes perhaps in the future. But from a functionality point of view, we're hoping to at least track and show you as a clinician what's due and what might not be due for a client. I don't know, Dr. Williams, if there's some additional clarity here as well.
So I'm not sure, and Miguel could probably chime in on what's been required in the past, but I think what we're planning on doing moving forward is every 8 sessions. So that's just entering data every 2 months, if I'm not mistaken, based on the journey map. And Miguel, am I?
Yeah, and so the other thing too, and I think part of what we want to be transparent about is that some of these the inventories may not stay. I think we brought up the recall as a really good example, and that's why we were taking a quick survey of what is actually useful to your practice, and so we definitely want to leave that door open for further feedback. We want to know what's useful to your practice, and we will, again, I think understanding that not everyone needs a PCL5. I think these are the types of discussions we're having. And so our hope is to reduce how much you're having to upload if you don't need to. So those are things that we're taking a pretty hard look at, really reducing things that really don't apply, or and add more work to your caseload. So we don't want to do that. We want to be cognizant of just, we're thinking simple, less is best, but as long as we're capturing what we need, we want to be able to stream that a little bit for you.
Awesome. And from a user experience point of view, this is also a way to track and be able to deliver to you as a clinician, just an additional method to be able to understand which assessments may or may not be due for some clients. And we can shift that around from a software point of view, but at least you get an idea as a clinician of where we're headed and what that looks like.
And we have a billing question, but we'll get to that in just a moment as well from Maggie.
Sure. And April, thank you for this looks great comment. We appreciate that. It's been quite the journey. So Miguel, I see a hand open if there's additional comment here as well. Unmute, sorry.
That's okay, it happens. So yeah, I think one of the other things we wanted to call out is, from what we heard too from listening to the providers is the constant struggle that existed sometimes where you had to reach out to a certain individual to get your unique case identifiers to be able to bill. All of that has been streamlined and it is now automated so that you no longer have to do that. So when you log into the portal, anyone that has been assigned to you in terms of cases will auto-populate as soon as you come on. So you no longer have to go back, try to find out what your case ID number is in order to be able to bill, especially when you're getting closer to that billing cycle, to the end of that billing cycle, when you've added a new client where you still might not have that case ID. We've streamlined it so that that it becomes available as soon as it's assigned to you, and you'll be able to see that on your portal as soon as you log in. So I just wanted to make that call out as well.
Awesome. And then thank you, Miguel. And then Maggie, we'll get to the question when we get to invoicing, and I'll get to introduce our Deputy Director of Business Operations, Lois, as well, who can answer that question. Great. And so another functionality here, just before I move on, is also, making sure that, even when there's errors in the portal, that providers have an ability to edit information too. So being able to delete sessions or erroneous sessions that may populate as you keep a log here is also possible. Great. So moving on to the next slide. Okay, so digitizing our assessments and what that looks like from a software point of view. So, and making sure that that is data compliant in terms of encryption and security. So what we've done is we've built some of these assessment tools into the portal itself. So for example, in an earlier screenshot, I showed you the data tracking form. And if you clicked into that, what would populate is essentially this screen right here. And in that top module, you'll see case number, date, session number, and that's already linked and tied to the client you have in your caseload. So that won't be necessary to fill out for you. The most important thing would be to filling out some of these assessment questions and just filling out the radio buttons here and clicking submit. And that goes directly into our HIPAA and PHI compliant and data secure database, which tracks this and kind of auto aggregates the score and compiles that information for Headstrong. And this is another way to kind of just, make this easy in terms of digital transfer and kind of digital entry. Great, so we're now at invoicing, and let me just quickly talk about the screen before I kind of hand it over. But essentially, another part is being able to track your invoices here and kind of having that record of history. So clicking into invoices, you'll be able to see the invoice number, which is auto-generated, the date, the session tied to the invoices, the status of the invoice, which will probably be helpful as well in terms of approved, in review, paid or submitted for payment, and some additional information. And let me queue up Lois here with Maggie's question. Will we still be billing monthly? And then if so, what is the time frame for when notes/billing is due?
Sure. Hello, everyone, and thanks, Parsh, for a great job. Yes, the billing cycle process remains the same. It's on a monthly basis for the previous month. And if your invoices are in along with your notes submitted by the 10th of the month, you will be paid the last day of the same month. If your invoices and notes are submitted after the 10th, you'll be paid the following month. So there's no change to the billing cycle. And I think I've answered that question.
Thanks, Lois.
For this billing period, we do strongly encourage you to utilize the portal to really give it a chance. For those that want to still utilize the old system, we're going to ask that you not send your notes to Cornell for liability reasons. They don't want to be able to, they don't want to hold on to them, since most of this transfer of care is coming to Headstrong. What we'll do is work with you individually to reconcile, for invoicing those notes, but we're going to ask you to hold on. If you do intend to utilize the old system, we don't want there to be a delay in billing, but if you use the old system, please don't send your notes to the file transfer system. That's why we strongly encourage you to use the new portal that's being launched on the 29th.
And Miguel, we have one more question. How extensive do you want the notes?
Yeah, I want to bring back Amy to this conversation, because we talked a little bit about this today, and I want us to so Amy, I'll let you sort of take a stab at that. But Charles, we're thinking of you in mind, wanting to reduce how much you have to send to us. So Amy, I'll give it to you.
Yeah, because I really want to only be making you put in what we are going to be able to use and glean and either use to improve your experience, use to tell our story better. And no one's reading thousands of progress notes. I can't believe that that's been happening. And so then you're just submitting these things, which is confidential and, people's information. And are we really using it for something that's necessary? There are other ways for us to look and see what you're doing. So my goal is to really look at this whole submitting of notes and move to something like every 8 sessions, you're also giving me a 1 paragraph, like progress blurb. And so for right now, though, I feel like it's premature for me to just jump in on day 3 and go, okay, this is what we're doing. I want to be more thoughtful, because I don't want to create a bunch of change on people for no good reason, or to then have to go back. Right. So for the meantime, just submit what you've been submitting, whatever you keep in your general practice, so that you're not having to do double work. To copy and paste that in, I think would be the easiest. But just know that we are looking at that, and I'm very open to kind of thoughts and feedback on that piece.
And then a question, I think this is appropriate for Amy as well. Dave writes, what if we do not know the number of sessions on long-term clients?
that's okay. Except for the from a billing perspective, I think, does it have to have a session number in the portal? Maybe, I don't know if that's a,
Yeah, Dave, I think with the new portal that'll automatically be generated for you. We already know how many sessions have been provided to date. So when you go into the portal and start adding, it'll add those sessions for you, but I could be misspeaking. So I want to bring Parsh in. I think the idea is that they automatically add the number of sessions as soon as you hit the radio button.
Yeah, it should. And obviously, as with any new software solution, if there's any hiccups, we'll work with you independently to kind of get that rectified. But essentially, our system on the back end tracks client session activity. So we should be able to kind of find that number for you.
And just 2 follow-ups from Christina first. For new psych evals done this month, I've already sent them to the Cornell file transfer. Do you want me to send into the new portal as well?
we do not, we don't have access to the Cornell file transfer. So anything that's gone to them, we don't have access to at this point. And so they've used it for clinical care, and that's great. But we would love it if you wouldn't mind submitting it to the portal. We would really appreciate that.
Also give you a practice lap in the new portal, Christina. So, if you
just what she was needing, though,
Yeah, I
double
know.
work. So I apologize for that.
A little humor. And then Maggie asked, can we submit notes and billing as we go, or do we need to wait until the end of the month and do it all at once? And that's probably
It is on demand, as I would say.
Good.
So you can do it as you go and try to make your lives a little bit easier, on a day-to-day basis.
Thanks, Parsh.
Great. So moving on to kind of the last couple components here and that's a good transition, I would say, to this last part here. This whole journey here, we want to keep the clinician's voice as part of this tool and the solution for Headstrong. So this is just the first vision and version of this portal for all of you to use. So the way we kind of structured feedback in the initial part is we used what Dr. Williams and Miguel talked about earlier, the Innovation Next focus group of clinicians to help us kind of create this first pass of this portal, use some of that feedback in terms of user experience, the clickability, the legibility, some of that. But as we've just seen with some of these questions and our talk yesterday, there are definitely features that we're going to have to change and move around, and we recognize that. So in kind of concise and iterative moments throughout the year, we'll be releasing new updates and changes that will hopefully make your lives even easier and automate a lot of this process that we're really hoping to achieve. And that's kind of the point and the vision we're trying to take with this portal as a product of Headstrong going forward. And we've talked about this throughout the conversation, but quite a bit of things that I just wanted to capture in terms of benefits to you as a clinician, in terms of centralization of data, making this easier, and then just from an organizational point of view, why we need to do this as well, and how this really consolidates a lot of data, not only from a clinical point of view, from a business operations point of view as well. Great. And I think that's it. The timeline I spoke about, you'll receive a welcome email end of this month. And don't forget, there'll be an FAQ guide, there'll be training videos, a few resources for you to rely on and look at as you first enter the portal and work your way through it. Okay, I think that's it. Yeah, awesome.
Okay, thank you, Parsh. Thank you, Miguel. Thank you, Amy. Thank you, Lois. And thank you, Laura, in the background. I actually took a question from a clinician on marketing materials a moment ago, Laura. So you have a homework assignment, and I'll get it to you. So listen, on behalf of all of us, we're at the bottom of, or close to the bottom of our allotted time. We have a hard stop in a few minutes based upon the scheduling of this Zoom. But I just want to say, on behalf of the organization, we really do appreciate the feedback and the comments provided tonight. They're all designed to make us better and in turn support you better. So this session known as a town hall is something we intend to repeat periodically in our desire to kind of be stronger partners with you on the communication side. And as always, be more transparent, speak frankly about where we are with things, and bring you along the journey that is associated with Headstrong 2025. There's a great team developing under Dr. Williams' leadership. And I can't be more pleased to have her now as our first Chief Clinical Officer. And she's a remarkable human being. She matches the talents of the people that spoke earlier with you. And we really do appreciate your participation. If there's one thing I've heard since I've been here, it's that your voice should matter more. And as we redesign protocol, as we redesign process, as we redesign the portal to keep pace with the things you'd like us to do, your voice is going to count. I can assure you that. And it's my desire as the executive director to make sure that we maintain communication with you throughout the journey of our months, our years together. I think Amy laid it out correctly. While our priority is always on the individuals you serve, you're right there next to that. And I think that that's important to remember. We exist for you. And we hear the small team that's assembled behind the scenes that puts gas in the tank, builds new portals, develops business opportunities, analyzes the data. It really is nice to see on the other end of this, the impact that that can have on your ability to serve people's lives. And that's what this is all about. We take the mission seriously. We are a strong team committed to everything we laid out today. Headstrong 2025 is not just a plan. It's not just a vision. It's what we're in the middle of. It's what we're building toward. And we don't get there without you. So stringing you into this conversation periodically. I know you all work long days. We're so blessed with your talents and your skills. It's not funny. And I appreciate you taking additional time to kind of keep pace with us and let us know along the way whether we've got something wrong, about right, needs an overhaul, et cetera. So I know there are comments coming through the chat that we'll address. A lot of them are thanks, but I'll shut up. It's my last thank you of the night. I'm going to kick it over to Amy and the rest of the team to do their closing comments, but love everyone on the net. Thank you for what you do. Amy.
Had to unmute. Hold on. I was busy chatting. Things I'm still learning. I love that Dawn said, are we going to see like FBI, CIA? And I'm like, oh, veterans and service members. And Miguel's like, hey, we see some secret people. So I am still learning. I hope you guys bear with me. I am so blessed to be here and excited to work with all of you. One thing I forgot to say is I plan, once we get our feet under us, for the clinical team at Headstrong to also be seeing clients alongside you and testing the processes and doing the same work you're doing, walking along with you. So thank you. I look forward to working with you. I appreciate you being here. And as much as Jim has complimented me, I can tell you definitely you've had a good team all along, and I'm really happy to be joining it.
Miguel, parting thoughts?
No, I just wanted to, I appreciated everyone's feedback. I think the best way to grow this is with you all. So I love the constructive dialogue that we had, and we want to continue that. So please feel free to reach out to us at the emails listed. Amy at getheadstrong.org, Miguel at getheadstrong.org. Always feel free to reach out. We're here for you. We know this transition isn't always easy, but we want to simplify that as best we can. And any support that we can provide, please feel free to reach out to us.
Thanks, Miguel. Parsh?
Yeah, nope. A big thank you. This world is really new to me. So from a technology point of view and an architectural point of view, I'm always curious to hear thoughts on user experience. So always feel free to reach out to me as well if you have any thoughts or ideas. Happy to hear them.
Thank you, Parsh. And I always do this to Lois. You get the last word. So Lois, over to you.
The last word is amen. Well, again, everyone, thank you. Thank you for joining us. And just a reminder, we're all here to support you through this. And you can still have access to the billing at Get Headstrong for any billing questions you may have.
That's billing at Get Headstrong, right?
.org. Yes.
Okay. Okay, everyone. We're going to close the afternoon, evening, depending upon your zip code. And we wish you all the best, and we'll be in touch over email and beyond. And don't forget, next week that new portal goes live. Get your early reps in there. I think you're going to find it something that is easy to use. And we're here to work with you, as Lois said, every step of the way. So have a good afternoon and good evening, everyone. And thank you very much for joining.
Night.